is capable of dynamic standing balance and reaching outside. So now we need to start prepping them for gait. So our pre-gait activities are going to focus on our stance leg first, because there is no swing without stance. And then we will transition into the swing exercises. So, I may have time at one point in my life to get organized, but I doubt it. I don't think my brain will let me. It was at one point. So we are going to do these activities. They can be done in the parallel bars. We are going to do them here at the high-low table, because that's where we're going to be anyway, right? We're doing the high perch. That's how we're getting them from sit to stand. And that's where we're going to be working on those dynamic balance activities. And so we're just going to continue on right from there. So we're going to work on our stance activities right from the, right after, oh, no, there it is. Right after the, dynamic standing balance. Okay, and you should have a check sheet. Stance activities. These are listed exactly the way that they will be listed on the practical. You have, now these activities are a little bit more specific, just because, there are gonna be specific things that you're gonna need to work on, in order to do gait. So, like on your check sheet, in red, it says, these things are for proprioception input, for the hip, and to work on hip extension. So the ones that are underneath that in red, that is what you'll be treating with that, okay? And then under the red, we're gonna be training knee extension. Then the exercises listed under there, that's what you'll be training. And then the treatment of hip flexion control, these exercises are gonna address that problem. So those problems or those issues, or you know, your scenario will say you're going to treat a patient for stance issues, for proprioception and hip extension. And so that will cue you that these are the exercises that I need to do with that patient. That makes sense? Okay, so just a tiny bit different.
How many exercises are we gonna do on the practical for?
This is the progression.
You just go in that order? Okay. That's
Yeah,
right.
so these are the progressions that you would have to do. I just have each little exercise listed individually. So, and these are the stance exercises. All movement of lower extremity is to take place with the unaffected leg. So, your affected leg does not move. It should not move. Because if you think about it, and we'll have the patient standing this way, you're gonna have to guard the stance leg. Our purpose here is we're moving this leg all over the place with different activities in order to weight this leg, find out its worthiness to hold, while this one does the swing. Because we can't have a reciprocal pattern without finding out if this leg will hold weight consistently and without hesitation. So that has to be addressed first. And then we will move on to working with swing on this leg. So with all of these stance activities, I mean, it makes sense, but sometimes students still get confused and they want to do the activities with this leg. So if this is the weak leg, this leg, if it stands, stays planted on the floor. Well, there's one where we step up and it kind of comes up, but this leg is, the focus leg is for stance. Stance, stance, stance. So this leg is gonna be doing all the work. Okay? Let me, I'm gonna make a copy. I literally broken it down as far as I can on the sheets. The very first thing on the exercise is doing the pivot. You know, so if you're standing your patient up, and you're doing the, having to do the strong side pivot. So that's literally the first thing, because you can't do the stance exercise until you do the pivot. So it's literally the first thing on here. So you're gonna start with the, or if we're working on input for hip proprioceptive input and hip extension, then we're gonna do the pivot to the strong side. And then we're gonna perform a heel toe step with the unaffected lower extremity. So that's going to, the emphasis here is going to be guarding, depending on what the function of your knee is over here. And it's going to be a weight shift. So a lot of patients, I know I've said this before, but a lot of patients do not want to put their weight over here. They're scared of it. They don't like it. It doesn't feel normal. We're working on proprioception, meaning that it's not normal. So when they go over here and it feels dead or it feels not normal, then they don't want to put their weight over there. So that makes it difficult to move this leg, because if they have even equal weight, because that's what we've been working towards, now we have equal weight, we still can't move this leg over here. We've got to unweight this leg, so everything over here, to be able to move this one, and that's pretty uncomfortable for them. So we have to practice getting weight shifting all the way over here to where the patient literally can move this leg freely. So, and making sure that our hip stays in extension and in neutral, that we don't get a dropout. So some of your patients may have a weak glute med, so that means that they would drop out the side, right? And some patients may have an abnormally weak hip extensor, which means they may drop out the back. So we may need to use some facilitation, either here or here. And facilitation is you're not pushing, holding it in there. You're just trying to get the muscle to fire by touch.
Is it the facilitation for the glute med?
Yeah.
Okay.
Well, we can't actually
Right,
facilitate the
'cause it's
glute
deep.
med. It's deep.
Yeah.
But yeah,
Okay.
yeah. You're just hoping something in there fires based on the fact that it's being touched.
Gotcha.
No, are we tapping yet or just touching?
No, just touching.
Okay, sorry,
Well,
I keep
I
fighting
know.
for it.
You're waiting to tap. Tap happens when we are moving with the patient. Tapping usually doesn't happen. Like tap happens a lot when you're doing exercises, when you're seated, or
Like activists.
it's really hard to manage everything you're managed and like
Yeah, okay.
tap on this. Does that make sense?
Yeah.
Pardon?
Are these posted online?
Yes, they are.
I'm just gonna take notes on this one.
Yes, they are posted online. So it's difficult to give that tap facilitation while you're trying to hold everything in and manage safety. Does that make sense? So it's effective it does the same thing all the time. It's just when is it appropriate to use it? That makes sense? Yes. So, but especially for stand spays, we just want it to hold. So a lot of times we're just literally just keeping a hand over the muscle that we want to work. So it would either be the glute med or up underneath the glutes there. Just to try to help them. And again, we're not shoving, we're not pushing. You know, if we wanted to keep them in hip extension, we'd go up a little higher and give them, give them a shove if that's what we were trying to do. We really just want some pressure on that muscle, just a little bit of light pressure on that muscle, just to say, hey, you know, do a little job for me. So depending on if that's an issue, then for glute med weakness or hip extensor weakness, then you know, hand placement may be there or there. As far as, and you'd be blocking knee with your leg like we've already learned for the dynamic standing. But they may not want to come to you. Instructions would be, we're gonna start putting weight over here on this leg, so in order to get you to do that, I'm gonna have you start moving this leg. We've gotta learn to trust this leg again. You're gonna be in a completely safe, controlled environment. This table's right here, you can hold on. I'm gonna be right here. You know, we're gonna be real good and safe. We've gotta learn to trust this leg again. I won't let your knee buckle. It may feel very strange, but the only way it's gonna start to feel normal again is if we stand on it, is if we work it, is if we do it. So this is the way that we get it to make it feel like it used to feel again. And I understand you're not gonna trust it for a while, and that's okay, as long as we can do the exercises. You know, so whatever you have to say to them to make them, you know, want to go forward with the exercises. So they may come over here a little bit, they may not come over here fully. You may have to reach around to the other side and get the opposite ASIS, and you may have to pull them over to you. I mean, it may be a, come here, come on now, a little more. Can you move the foot yet? So, it's just gonna kind of be a process. You wanna see what they can and what they're willing to do, but if they do not do a full weight shift, finish it for them, okay? All right, so, once we get the weight shifted over and we have addressed any facilitation that needs to take place over here, then you're gonna instruct your patient to do a heel toe. So that's the motion that they're gonna do with this foot, is they're just gonna put heel down, toe down, heel up, heel back up, and then put it back where it started. Now, during that process, what's gonna be happening over here?
Shifted weight.
I mean, there's gonna be a lot of shifting going on, right? So you want the patient to hopefully do what comes normally. As they're moving this side, you're hoping that the weight shifts over and a little bit forward. You don't want that foot to come up off the floor. So you hope the weight shifts forward a little bit, and then you're hoping the weight shifts back laterally, and then back laterally. Because this is all you're focused on. You're gonna give them one instruction on this, and you know, you may have a tape line down. You know, if you wanna measure their stride length, you don't want them stepping out here. You don't want them doing this little baby step. Because then you get no shift. So, you know, sometimes it's good to just proactively have them maybe take one step, and so you know kind of where you want the heel to hit to be able to get that weight shift that you want on this side. That's where we're focused. That makes sense. So that's what you want to facilitate and make happen on this side. And the mechanism we're going to use to do that is a heel toe over here. Okay? So that is your first one. After we've accomplished that, in a very nice and strong, safe environment, we now have an idea about how they feel about putting weight on this leg, right? Now we know they are either avoiding it like the plague or they are kind of going along with it and are being a pretty good sport about it. So now we're a little bit more prepared to move forward with what the next one is. So for the next one, we need to face the table, so you'll have to do the strong side pivot again. Okay, and then you're going to face the table. You may want to bring it up just a little bit for them. And for this one, you're going to need the yeah, it's step out to the side. Okay, so you don't want them too close to the table, so when you pivot them, you may have to like shift them around so that you can position their feet, because you don't want them leaning on the table for support. They can use their upper extremities for sure. If it's flaccid, it'll be in a sling. If it's spastic, it can do what it wants. We can use it, it can draw up, whatever. But use the table for support. And this time, so this one's the weak one, we're going to step out to the side and back. Step. So this is the one where we're actually going to travel. So we're going to see if they can actually sidestep. Now we are going to move this leg at this point, but we're going to move it in a deduction, which is usually the way that it will move a little bit, but we may have to assist the leg. So I'll holler for one of you all in just a second. So I'm going to show you the weight shifting first. So what you will do is you will shift the weight over to this leg and cue them to step out with this foot. You shouldn't have to cue them to put weight over here because they do that, right? And then you may have to help them scoot this leg in. Now we have to weight shift over here again. They should be able to do this all by themselves. And then the weight shift should happen, and then you may have to help them pull the leg forward. So just a couple of steps down the table to tell you, without a ton of cues, you're just going to tell them, okay, now we're gonna take a couple of side steps. I will guide you with my hands about what you need to do, and I will help your weak leg do what it can. That's gonna tell you a lot of what they're capable of, because we don't have to use knees. Knees are gonna stay locked, right? So if we have to help them, we just stay to the side, keep the knee locked, and drag the foot along if that's what is needed. We're not like picking up, putting down, you know, this type of thing. We're keeping both legs locked, so we're pretty safe. You know, there's not much chance that we're gonna go, because everything's kind of in extension, and we're just seeing. This also is a great sequencing exercise, right?
Yeah.
Because it's gonna tell us, if we tell them we're gonna take a couple of side steps that direction, not left, not right. You can say towards your strong side if you want. You can say that direction. Whatever feels appropriate for that patient at that moment and that time is what you should use. Never left and right. Never ever left and right. Some of us don't know our left and right on a good day, let alone after a stroke. Just saying. So, it's going to tell you a lot about their sequencing ability, about their coordination, because to this point, this is really the first point where we're asking them to do something reciprocally, right? So, we don't wanna fill their head full of a whole lot of stuff. We wanna see what happens naturally and organically and help them where they need it. It just gives us a good idea about coordination, sequencing, plus, how are they gonna do with a shift that then has a move afterwards? So here we did a shift, but then the leg didn't move afterwards. So now, we're doing a shift, up, and then trying to move this leg afterwards. And then a shift, and trying to move this leg afterwards. How do they process that? Do they initiate the shift off? Do they initiate the shift on? Do you have to do it all with the pelvis? That's all the things that you're looking for.
Whenever you were doing that, the left one was the affected extremity.
Yes,
Okay.
yeah, that's the same one that was here.
Right.
Just turn.
Right. Okay. In terms of like guarding, you said we want to keep the knee locked.
Depends on if they're a 2+ or less, gotta stay locked.
So whenever they move, we just move with them to keep our
Oh,
leg.
yeah.
Keep our leg right
You're
where their
just,
leg's
you're
at.
part of them.
Yeah.
That's what I said, I'm gonna have somebody come up here in just a second
Okay.
and show you.
Okay.
But,
Can you show us the guarding for that heel toe as well, cause I was wondering about that, where we would be.
yeah, so, but that's, the shifting and the telling of the explanation needs to happen ahead of time.
Yeah.
Not during. That's because we want the brain to work. We don't want to spoon feed them what we need them to do, and especially with this sidestep one, because it's used a lot to help us hone in on where the problems are. Okay, alright, somebody wanna come up?
I'm kinda done this.
Yes. So go ahead and face that wall, and I'll show them the guarding for the heel toe.